Good evening. Welcome. Assalamu alaikum and good evening. Welcome you all to our fortnightly session of the Oncology Club in Gynecological Malignancy. আপনি সবাইকে অ্যাডমিট করেন, এটা আমার কানের কাছে আসছে তো। Today our topics is the real life challenges in gynecological oncology practice, and today's topics is the preoperative evaluation of ovarian cancer management. As all we know that we are doing the tumor board for around 1.5 years. In spite of that, we are facing the cases in different problems, how the preoperative ovarian cancer patients preoperatively it should be evaluated, and when should we do surgery and when should we not, and what type of the assessment should be done. For that reason, we have decided to arrange this type of topics in between the tumor board, as because if we are give more emphasis on especially on the different topics, then I think it will be more beneficial for all of us. Our today's the faculties is the Dr. Manush Bishwas. Sir is the Associate Director and Gynae Oncologic Surgeon, Max Institute of Cancer Hospital, Max Super Specialty Hospital, Dishakat, New Delhi. And our another faculty is Dr. A.K. Goodman, who is the regular mentor and who is always with us. We are very grateful to both of these the faculties today. And our today's presenter is Dr. Tahmina Akhtar. Dr. Tahmina Akhtar is working in National Institute of Cancer Research and Hospital. He has completed a fellowship in obstetric and gynecology and also the fellowship in gynecological oncology. And our inspirator are Dr. A.F.M. Kamaluddin. He is the scientific secretary of Oncology Club. He is always behind us and always support us for making the program more fruitful. And another is our Professor M. Shariful Alam sir. He is the General Secretary of the Oncology Club. Last but not the least, the man who is from very beginning of the program, in each and every program from beginning to end of the session, they always with us, the president of the Oncology Club, Professor Dr. M.A. Hai sir. Cancer is a word, not a sentence. So hope is living with courage and confidence. I think as because all the faculties who are supporting us for last around 1.5 years, for their support, we are not giving up hope. So we will proceed, and we think we can overcome all the calamities, and we can serve the cancer patients more precisely and more accurately. Thank you all. So now I request our president of the today's sessions to say some things and give us permission to start the session. Hi, sir, please.
Thank you, Dr. Shahana. Bismillahirrahmanirrahim. As you know, we are running this type of webinars since last 1 year. It only to enlighten our younger generation. They are in the field of gynecology.
আব্বু আল্লাহ তুমি কখন যে কি করবা
মেহেদি
Without any delay, I think we start late by a few minutes. Shana, start immediately. Our subject is preparatory evaluation of ovarian cancer. Preoperative is a very important thing. So let us start immediately.
Thank you, sir. Thank you very much. So I request the presenter of today, Dr. Tahmina Akhtar, to present your topic. Tahmina, please.
Thank you, madam. Madam, is this screen visible?
Yes.
Am I audible, madam?
Yes.
Assalamu alaikum, everyone, and thank you for giving me the opportunity to present the topics, such an important topics in the platform of Oncology Club. Thank you, madam. Welcome to today's topics. This is preoperative evaluation of ovarian cancer management. Ovarian cancer is the most lethal gynecological cancer. No recommended screening test is for ovarian cancer, and more than 75% of affected women are diagnosed in advanced stage. Prompt attention to symptoms with appropriate workup is mandatory. Surgery is the mainstay of treatment. Proper selection of the surgical candidate and meticulous surgical preparation will improve the treatment outcome. Patients who are not candidates for optimal debulking should be considered for neoadjuvant chemotherapy, followed by interval debulking surgery and further chemotherapy. So today's our topic is preoperative evaluation, and these topics is divided into 4 parts. That is workup and the surgical preparation. And the workup includes the history and clinical examination and investigations, which are tumor marker and imaging. And the surgical preparation include serum albumin ligand along with other routine investigations to evaluate the patient, and the surgical skill, available resources, availability of the multidisciplinary team, which is the part of infrastructure. So at first I will tell regarding the diagnostic workup, and the diagnostic workup includes history taking, clinical examination and investigation. The history taking will include the history taking of age, menopausal status, symptoms, fertility status, and drugs used due to fertility, contraceptive history, medical history, family history, and history of other cancers should be taken. Complete physical examination will include general examination, breast examination, abdominal examination, pelvic examination, and the groin, axilla, supraclavicular areas should be examined very carefully with the auscultation of the lung. The investigations include the imaging and the tumor markers. Imaging plays important role in the diagnostic work. When a symptomatic patient or incidental findings of an adnexal mass, she will be referred for ultrasonography. An ultrasonography by an expert sonographer will give reliable diagnosis. Transvaginal ultrasonogram is the standard first-line imaging. In ultrasonography, various scoring systems have been developed. The most important scoring system is risk of malignancy index, which is a numeric score based on menopausal status, CA125, and ultrasonogram-based morphology. That is, risk of malignancy index equal to menopausal status scoring, CA125 level multiplied by, and then ultrasonogram-based morphological findings. The ultrasonogram-based morphological findings includes solid areas, multilocular cystic area, ascites, bilateral lesion, and intra-abdominal metastasis. The threshold for probability of malignancy is 200, and the sensitivity of risk of malignancy index is 84%, and its specificity is about 77%. The consensus statement of ESGO, ISUGOG, IUTA, and ESGE consensus statement on the preoperative diagnosis of ovarian tumor revealed IUTA adnx model after exclusion of normal ovaries, and physiological changes should be performed. The IUTA rules include simple rules, that is features of a benign mass or B features. It includes 5 features. They are unilocular cyst, a smooth multilocular tumor, which largest diameter is less than 100 mm, presence of solid component with largest diameter less than 7 mm, presence of acoustic shadow, and no blood flow. A mass is classified as benign if at least one B feature is present and no M features are present. The features of malignant mass, that is M features, include, it also includes 5 features that are irregular solid tumor, irregular multilocular solid tumor with largest diameter more than 100 mm, presence of ascites, at least 4 papillary structures, very strong blood flow. A mass is classified as malignant if at least one M feature is present and no B features are present. Iota-Adenix model is very important because it does not only differentiate benign and malignant neoplasm, but 4 different subgroups, that is borderline, stage 1 cancer, stage 2 to stage 4 cancer, and secondary metastatic cancer can also be assumed. It includes 9 variables. Among them, 3 are clinical variables. These are age, serum CA125 level, and the type of center, either oncology center or other hospital. Ultrasonographic predictors include maximum diameter of the lesion, proportion of solid tissue, more than 10 cyst locules, number of the papillary projection, acoustic shadow, and ascites. The sensitivity and specificity of these diagnostic modules reveal that transvaginal ultrasonography is highly sensitive and specific for diagnosis of an adnexal mass, malignancy of an adnexal mass. MRI is also very sensitive and specific, but the MRI is expensive and it is only performed when the adnexal mass diagnosis through the transvaginal ultrasonography is inconclusive. The diagnostic workup also includes the tumor marker. The tumor markers are CA125, that is 50% of early stage and 90% cases with advanced stage epithelial cancer. The CA125 is raised. CA99 is raised in case of GI tract cancer or ovarian mucinous tumor. Carcinoembryonic antigen is usually a marker of colonic carcinoma, but it is raised in case of 88% of mucinous and 20% of serous. Inhibin is increased in case of granulosa cell tumor, and in case of alpha fetoprotein in yolk sac tumor, ACG in non-gestational choriocarcinoma, and lactate dehydrogenase is usually raised in case of discharge. The study revealed accuracy of CA125 in the diagnosis of ovarian tumor, which revealed that CA125 is the best single protein biomarkers for the preoperative characterization of an adnexal mass. Another study revealed combination of detection serum CA125, CA99, and carcinoembryonic antigen was a promising biomarker for the epithelial ovarian cancer diagnosis with relatively high sensitivity and specificity. In 2011, very important study revealed that carcinoembryonic antigen level is raised in case of adnexal mass when there are 68% cases non-ovarian malignancy, and the ratio of the CA125 and carcinoembryonic antigen is more than 25, which favors ovarian primate. The other tumor markers, especially in germ cell tumor markers, the study reveals that alpha fetoprotein and beta ECG are elevated in yolk sac tumor and non-gestational choriocarcinoma respectively. Now, the study between the primary and metastatic mucinous adenocarcinoma in the ovaries revealed that 77% of the mucinous carcinoma in the ovaries were metastatic and all were bilateral and less than 10 cm in size. Is routine gastroscopy and colonoscopy reasonable in patients with suspected ovarian cancer? No, the study revealed that it is not routinely needed. Risk-adapted gastroscopy or colonoscopy strategy based on imaging and examination and tumor markers. So, when the GI tract will be evaluated, when the patient is symptomatic, that is colonoscopy revealed, colonoscopy should be performed when there is recent history of diarrhea and constipation, frank or occult blood in stool. Endoscopy will be performed when the patient presents with nausea, vomiting, and hematemesis. Combination of the bilateralism or tumor size, small size less than 10 cm in imaging findings, and when the carcinoembryonic antigen or C99 is elevated, or the ratio is more than 25. Ultrasonography or mammography will be performed, of the breast should be performed in case of breast mass and family history of breast cancer, axillary mass, or hereditary breast ovarian cancer syndrome. Endometrial biopsy and endocervical curettage performed if the patient presents with irregular menstruation or postmenopausal bleeding, and if a premenstrual girl present with adnexal mass karyotype is an important investigation to be performed. So after the diagnostic workup of the primary ovarian tumor, the treatment plan should depends on multidisciplinary setting. Now there is judgment between the selection of the patient for surgery, that either it will be primary debulking surgery or interval debulking surgery. Study for the patient selection for ovarian cancer for debulking surgery revealed that the clinical pathological factors that will affect the surgical outcome of a patient are divided into 4 groups. That is patient-related factors, age, performance status, comorbidities, and nutritional status. Cancer-related factor, that is grade, stage, tumor extent, and size. Platinum-resistant molecular subtype. Residual treatment-related factors include residual cancer after surgery, time from surgery to chemotherapy, complications during treatment, and institution-related factor, that is infrastructure, that is surgical skill, available resources, availability of the multidisciplinary team. Among these factors, tumor extent is the only cancer-related factor which should be evaluated preoperatively. So, how the extent of the disease can be evaluated? It is usually evaluated according to the NCCN guideline. It has been recommended that the complemented imaging to evaluate the extent of the disease. That is, CT scan of whole abdomen and pelvis with contrast. It will exclude the secondary cancer to assess the abdominopelvic metastasis for preoperative staging and estimation of the resectability and surgical treatment. X-ray chest, more accessible and cost-effective, but CT chest can be performed, which will reveal pleural effusion, pleural or pulmonary metastasis. And MRI and or PET CT should be performed when the CT scan results are inconclusive or intermediate. Imaging before cytoreductive surgery in advanced stage epithelial cancer patients, the study revealed CT scan is the standard of care for preoperative evaluation of ovarian cancer patients. And the study regarding the assessment of the predictability of the resectability of the ovarian carcinoma revealed that prediction of the resectability by computer CT scan is excellent, and ascites, omental cake, mesenteric disease, paracolic gutted deposit, diaphragmatic deposit, and pleural effusion are identified as features against resectability. Another study revealed that diffuse peritoneal thickening and large volume ascites was associated with a very low rate of optimal cytoreduction. So, the other predictors of the suboptimal debulking are extensive disease in the parenchyma of the liver, in the lesser omentum, diffuse involvement or deep infiltration of the stomach and duodenum, head or middle part of the pancreas, in the portohepatis, truncus celiacus, hepatic arteries or left gastric artery involvement. The recent update in the to predict the resectability of the ovarian cancer is the faculty laparoscopic scoring system. It is a laparoscopy-based score predicting the resectability of epithelial cancer, taking into account 7 critical parameters. And if the score is more than 8, it is unresectable in about 100% of the cases. Now, very important factor, that is patient-related factor. First of all, age is an important issue. Elderly versus young patient. Impact of age on 30 days mortality and morbidity in the patient undergoing surgery for ovarian cancer revealed that the study revealed that age was a significant predictor of 30 days post-operative morbidity and mortality. Youngest patient, when fertility issue desired, fertility sparing surgery should be considered if feasible. In elderly patient, ability to cope with stated or to major surgical interventions should be considered, and the patients developed frequent postoperative complications, that is in 9% of cases more than 80 years of age group. The patients also develop organ failure such as chronic kidney failure, cardiorespiratory disease, and neurological deficit. So patient over 80, extensive surgery in neoadjuvant chemotherapy followed by interval debulking surgery or delayed surgery should be considered, and frail with multiple comorbid patients, primary chemotherapy with no surgical intervention can be an option. Another important factor is the strong cooperative oncology group performance status. These scales and criteria are used to determine appropriate treatment and prognosis. These will also assess the progress of the disease. And in this performance status, if the patient is ambulatory and capable of self-care but unable to carry out any activities, it is graded as 2. And if the patient capable of only limited self-care confined to bed, it is considered as grade 3. Patient over the grade 2, that is 3 and 4, should be considered for the neoadjuvant chemotherapy followed by interval debulking surgery. The study regarding the performance status revealed that the predictive ability of CT scan based model of resectability is improved by integrating ECOG performance status. The nutritional status of the patient is very important. Severe malnutrition can be defined when there is 10% weight loss over 2 to 3 months or history of inadequate oral intake longer than 7 days. 2/3 of the ovarian cancer patients are malnourished, and associated cachexia, loss of muscle weight, and hypoproteinemia occurs. Malnutrition is due to metabolic effect and the mechanical complication of the disease, that is bowel obstruction, nausea, vomiting, poor oral intake. Serum albumin is a parameter for assessment of nutrition status through the prognostic nutrition index. The serum albumin level, when less than 35 grams per liter, it is defined as hypoalbuminemia. Patients with low serum albumin level are 5 to 10 times more likely to develop severe complications after debulking surgery, and mortality rate is 12%, which is 4 times higher than that the patients having normal serum albumin level. Reduced protein intake, cancer-related systemic inflammation, and muscle protein depletion causes hypoalbuminemia, which will reduce immunity and impair repair capacity, and ultimately the patient develop post-operative morbidity and mortality. A study regarding hypoalbuminemia revealed that preoperative hypoalbuminemia is an independent predictor of poor perioperative outcomes in women undergoing open surgery for gynecological malignancies. And surgical thromboembolic pulmonary and infectious complications and 30 days mortality were higher. Preoperative albumin levels less than 3 grams per dl was at a very high risk of perioperative morbidity and 30 days mortality after open surgery. The NCCN guideline has recommended evaluation of nutritional status is recommended as a part of baseline workup, and it is important to determine as the patient is good surgical candidate and for preoperative planning. It is very important to improve the nutrition. At first, routine investigations should be performed for the anesthetic fitness of the patient and to evaluate the patient, to assess the risk of the perioperative adverse event, characterize existing medical condition, identify any unrecognized risk factor, anticipate issues that may arise perioperatively, make appropriate investigations are complete blood count, where to identify anemia, thrombocytopenia, and to ensure recovery of neutrophil after chemotherapy. Liver function test, renal function test, cardiorespiratory system evaluation, and the glycemic status of the patient, and blood group and RH tracking, and thyroid function test and serum albumin should be included in the preoperative testing. Anemia is one of the most important factors should be considered preoperatively, because anemia around the time of surgery will adversely affect the perioperative events. Imbalance between the oxygen supply and demand is ischemia and adverse perioperative outcome. Correction of anemia with hematinic supplementation or blood transfusion is important prerequisite. It will increase the risk of infection, blood transfusion reaction, and increase hospital stay or death. In case of urgent intervention, steps should be taken to minimize blood loss, optimized tolerance to anemia, and transfusion of red cell concentrate. The thromboprophylaxis is very important because elderly patients, open abdominal surgery, prolonged and extended surgery, or history of prior advanced thromboembolism are considered high risk for thromboembolism due to surgical procedures. Thromboprophylaxis with low molecular weight heparin or fractionated heparin commenced preoperatively combined with mechanical method. The thromboprophylaxis is stopped 12 hours prior to the incision and restarted 12 hours after surgery. Another important issue that should be considered during surgical preparation is the enhanced recovery after surgery. It is a multimodal perioperative care pathway designed to achieve early recovery after surgical procedure by maintaining preoperative organ function. ERAS, reducing profound stress response during surgery, promote insulin sensitivity and attenuate the breakdown of protein. ERAS protocol promote faster recovery, reduce operative stress, support organ function, reduce morbidity, less workload for nurses, fewer readmission, shorter hospital stay, and large saving potential. The stress response of the surgery, which occurs due to combination of hormone release and various inflammatory response, loss of insulin sensitivity, and increased catabolic state. The ERAS is the modulator of the stress response on surgery. There are three components in case of multidisciplinary ERAS program, that is preoperative, intraoperative, and postoperative. But today, the topic of discussion is the preoperative component, that is patient counseling or optimization, no prolonged fasting, fluid or carbohydrate loading, no selective bowel preparation, antibiotic prophylaxis, and thromboprophylaxis. The study regarding the ERAS, that is the implementation of enhanced recovery after surgery protocols in ovarian malignancy, revealed routine bowel preparation should not be used. Patient permit to drink fluid 2 hours and solid food until 6 hours, and routine nasogastric tube avoided. Last but not least, the infrastructures should be considered. The study regarding the impact of the structured quality management program on surgical outcome in primary advanced ovarian cancer revealed surgical skill and available resources are prerequisite for performing the complete surgery. Establishment of quality management programs increased the rate of complete resection from 33% to 66%. So from this presentation, the take-home message is accurate characterization of adnexal lesion is paramount importance to define appropriate treatment path. Diagnostic accuracy of ultrasonography in differentiating between benign and malignant ovarian mass is related to expertise of the sonographer. Radical surgery aiming at complete removal of macroscopic disease, suboptimal cytoreduction does not provide any survival benefit. Selection of the patient for primary debulking surgery on neoadjuvant treatment must be carried out in a center with multidisciplinary setting. So thank you all for patient hearing. Thank you, madam and sir. Thank you all.
Thank you, Dr. Tahmina, for your excellent and the elaborate presentation. So, Mehdi.
Thank you, madam.
Please stop your slide. Yeah, Manoj sir is not here. Mehdi.
No, madam. Sir joined but late.
Okay. As all we know, at the first of the presentation, I have told you that as these all types of things we are discussing in our everyday tumor board, even after that, there's some things are missing. So we have chooses these topics as because all we know the maximum ovarian cancer patients, they are with protein, they are the albumin level, and they are reduced albumin level, hemoglobin level, and also sometimes previously we use the mechanical bowel preparation, and long time the patient has there are nothing in my mouth before surgery and everything, and sometimes we have seen that the the patients who are attended in the periphery, that is in the sub center or in the district hospital. In that cases, we are thinking that there is no imaging, that is CT scan. So how can we proceed with this patient? So everything, the Dr. Tahmina Akhtar, he has told everything here. At first, I would like to request our 2 days faculties, today our 2 faculties, Dr. Manush sir and Dr. A.K. Goodman. Probably Manush sir has left for some reason, and I think he will join soon. At first, I request Dr. Annie Catherine Goodman, our mentor, to comment to 2 days presentation, and also all the participants are requested to put their questions on the chat box. And if you have the seniors have any questions, you please raise your hand and ask the questions to the presenter and also the faculties. Dr. A.K. Goodman, please.
Hi there. That was a brilliant, brilliant talk. I mean, you basically, Dr. Tahmina, you took us from asking the question whether there was an indication for surgery because this was a malignancy, what was the probability of it being a malignancy, what was the workup to identify whether this was a malignancy, to assessing preoperatively the surgical resectability in the setting where you were pretty sure it was going to be a malignancy. So you went through all that, and I completely agree with you about the CT scan. And Dr. Shahana, I'll get back to that point. And then you took us through just assessing surgically with the idea that if you couldn't cytoreduce, you would abandon the case for chemotherapy or neoadjuvant chemotherapy using the Fagati score. So it's very nice. And then, as I'm sort of listening to your lecture, I'm thinking, yeah, but what about the comorbidities of the patient? You then talked about the comorbidities of the patient and all the factors that are so important preoperatively to understand whether someone can have a good outcome or there's going to be complications. And finally, you talked about the ERAS, which is sort of our latest and greatest moment in the past few years, which is to not have our patients coming in dehydrated, to have them hydrate with a high carbohydrate load. Of course, if they're diabetic, you have to be careful that you're not over increasing their glucose, and then the whole issue of antibiotics and DVT prophylaxis. So very beautiful range. I feel like if everyone could just memorize your talk, we'd all be better for it. So congratulations. I'm not sure, actually, I have much more to add to that. Really, you covered it all. I would say, I couldn't remember if I heard you say checking the diabetes screen. We now routinely check a hemoglobin A1C to make sure that if someone has diabetes, that's in control preoperatively, because that can be a risk factor. So I think that's all. I agree with all that stuff. I mean, I think that Dr. Shahana, you're talking about, well, what if you don't have the resources to do all these things? I mean, that's a very kind of challenging issue that would lead you to ask the question, who should be caring for women who most likely have an advanced ovarian cancer, right? Do you have a model where you refer everyone to cancer centers? And should you devote your resources in a country from a national cancer strategy to developing referral centers? Or do you have a system where you just try to, in the communities, regardless of where you live, treat your patients there? And that's clearly going to be a question for the Ministry of Health, right? Because that's really a very big issue, right? We're on the ground taking care of patients, but actually it's the infrastructure that we live in that allows us to care for the patients. Do we have that infrastructure? So I would just say that, because ultimately for that physician in rural Bangladesh who sees the woman with a pleural effusion ascites, a large omental cake, you can palpate it on exam, you do a bedside paracentesis, you don't really need much more than a needle, right? To retrieve fluid, you get a cytology that shows cancer. What do you do with that information? Well, either you can refer to a tertiary care center, or you can have someone locally give neoadjuvant chemotherapy and then refer? So those are those questions that you need to deal with on a policy level. And I'm curious to put that discussion back to you all. So thank you for allowing me to comment.
Thank you. Tahmina, please stop your slide share. Tahmina,
Yes, madam.
please stop. Yeah. Thank you, Dr. A.K. Goodman. Is there Manush, sir?
No, madam.
No, okay. Dr. A.K., your question is who is patients? We have taken the model that who is patients should be treated by our gynecologist and who is patient should be treated our the colleagues, that the obstetricians. As you know, is in Bangladesh, we have what was the past, present, and future about the cancer patients. As you know, this is the National Institute of Cancer Research and Hospital, which is the first hospital in Bangladesh who is taking care of the cancer patients. And our teacher, Dr. Khurshidjan Maula, who had introduced the gynecological oncology in Bangladesh. From that time, it was only the 50-bedded hospital at OPD basis in our Rotary Club. And from there, it is a 300-bedded, and up to that, at the end of this, it is a 500-bedded hospital. And maximum of our gynae oncologists who at first they are working in this hospital, from there they are distributed in different hospitals. And nowadays we have the super specialty in the gynecological oncology. In this subject, there is the fellowship program, and till date we have the 29 fellow in gynecological oncology, and also that is the different unit in different hospital, that is Dhaka Medical College Hospital. There is this gynae oncology unit, the Bangabandhu Sheikh Mujib Medical University, here is the gynae oncology unit, and also the Medical College Hospital. As you know, the maximum patients, we are the maximum of our patients, they are living below the poverty, and the gynecologic and obstetrician, they are dealing the huge number of patients, and maximum patients, when they try to refer them, they cannot go there, and they have to treat the maximum patients. In that cases, we are trying to upgrade our knowledges and upgrade our general gynecologist colleagues who are treating the patients, and we are trying to give the message to all the doctors, when should they deal the patients, and at what mass level they should deal the patients, and when they will do the surgery, and when they will not, and when they will the patient, what type of investigations and what they will do. And you will be happy to know that our government we have the cancer center in 8 different divisional level, and now it is I think it will be in next 1 or 2 years, we will get the 8 district level hospital, and that will be 100-bedded cancer center, and our patients will get the better treatment from there. We have the.
Can I just, I'll just add just a reflection. You have the wonderful gift in your country of having a lot of medical schools, and you have a lot of physicians. There are some countries where it's 1 physician per million people, right? You in Bangladesh have actually more problems with nursing shortages, I think, than physician shortages. I mean, I'm sure there can always be more doctors and nurses to care for patients, but that's not your issue. To your point, you have some amazing high-level, high-quality tertiary care centers in Dhaka and in Chittagong and in Sylhet, where if someone is lucky enough to geographically live close there, they can be referred in. Just to throw it out there, there are places in the United States that are very remote. When you think about the United States, you think about New York City and Boston and Houston and that kind of stuff, but there's lots of places where it's hundreds and hundreds of miles from where you live to a medical center. And we actually have a very, very big problem with doctor and nursing shortages in certain parts of the country. We have tried to correct this, or at least offer care, especially specialty care, by doing other services such as telemedicine, where, for instance, Alaska, the state of Alaska, which is very remote, got a lot of villages and small towns, but not a lot of medical centers. And so another state, will have a telemedicine service where they talk to the local provider, who may not even be a doctor, maybe just a physician assistant or a nurse practitioner, and give them instruction for the dose of chemotherapy to use. We'll look at the x-rays online and so forth. So just to throw it out there, there are some creative ways of trying to do subspecialty care locally in a remote community when there isn't the resources, but you have the ability to bring in by telemedicine some other opportunities for care. It's interesting.
Yes, but as you know, we have during the COVID time, we had the telemedicine system, and that time the patients who are not attended in our cancer hospital, where there is the telemedicine and we have the phone number, and the patients and all the patients who are attended in our OPD and for their follow-up or any problem, they have called us, and one of our doctor and one sister, they are attended in OPD, and they answer the questions of those patients. And not also another thing is that, as you know, we have the fellowship program gynae oncology, and we have different fellows, and the all are the maximum are the government candidate. And as when there is they will get the preference to serve in those areas. That is we have as you know, I have told you that we have the 8 cancer centers. The government has decided in 8 divisional hospitals. And also in medical colleges, if those doctors who are trained and who have got fellowship in gynae oncology, if they are posted in those areas, they can serve the patients there. And not only this, by the platform of this oncology club, as you have seen in last 1.5 years, we are trying, and I think that our general guide, the OBGYN colleague, they are very much, they are benefited for this, and everybody, even when they're treating their patients, even their OPD and also during surgery, they regularly talk with us and they get the advice from us. As when they do not, they counsel it, at least they counsel the patients that you will have to do this and when to, and now they are accustomed with this, that when to do the surgery and when not to do, and what type of surgery. And sometimes you know that we have seen the patients in ovarian cancer, they have given that's only the transverse incision, the surgery has completed. And in a postmenopausal lady, an ovarian tumor, single ovary is removed and other ovaries. But I think through this platform, the maximum the patients are getting the benefited. I think it will be more helpful for these patients. I think our scientific secretary, Dr. F.M. Kamaluddin Bhai, he will give more the explanation about this. Kamaluddin, F.M. Kamaluddin Bhai, please.
Madam, council is absent.
Join kare nai?
No, ma'am.
Hi, sir, please. Join kare nai?
Aisha is present.
Our different senior doctors, some of our teachers and our senior doctors, obstetrician gynecology professor, Dr. Jinat Nasrin, and also the Dr. Shahi Farzana Tasnim, and all these are joined. I think they can answer the questions. All right. Shahi Farzana Tasnim, Appa, are you here? Shahi Farzana Tasnim, Appa. Kausar Nigar, Dr. Kausar Nigar. Assalam. Dr. AK has asked different questions. Do you like to answer those questions, and would you like to give any comment on this?
Madam, we are benefited through the oncology club program, and sometimes when you arranged this workshop, we have learned about some operative techniques, and from this oncology club program, we learn a lot about the management, about the about our about the management, and about the issue. And sometimes we refer the patient in NICRH when necessary.
Dr. Brigadier General Suraya, I think, is the one of the senior most gynecologist and who is very much interested in oncology practice. Dr. Brigadier General, Professor Brigadier General Suraya. Suraya, please.
Oh, thank you, Dr. Shahana. Am I audible?
Yes,
Dr.
yes.
Shahana, am
Yes,
I audible?
Yes, yes.
Oh, thank you very much. Today's presentation was excellent, elaborate, and very informative. Management of adnexal mass is very important. You have spoken about the management of adnexal mass many times in this platform. I think all the OBGYN specialists of Bangladesh have gathered many knowledge from your presentations and from this oncology club. So I have nothing more to say, but whenever there is an adnexal mass, whatever is the age of the patient, we have to preoperatively, we have to assess this very carefully about its nature. At least we have to exclude there is no malignancy before starting any operation. And we must have adequate resources to manage the patient. One thing we must remember, always remember, we should not harm the patient. We should not hurt the patient. We should do our best for the benefit of the patient. And when there is any requirement, you should refer the patient to concerned specialist. And preoperative, postoperative care, both are very important to reduce the morbidity and mortality of the patient. And follow-up of the patient is also important. Thank you, Dr. Shahana.
We have some questions in the chat box. I think we should ask those to answer this. AK, please. The first question is, shall we follow up an ovarian cancer by only CCT abdomen and chest? Isn't PET CT better? Okay.
So, yeah, sure. So I actually, I actually would suggest starting with the CA 125 and the physical exam and assessing the patient's symptoms, because really, if your CA 125 is normal and previously it has been elevated, then you don't really need to do other imaging. I mean, you can if you want, but you have a very sensitive tracking system, which is this blood test. So there are definitely some patients where they do not have what we call a tumor marker. That is, they came in, they had an advanced ovarian cancer, their CA125 was 25, it wasn't helpful. That's not really the way their cancer is working. But a lot of people that come in, their CA125 is 500, it's 1,000, you get it down to 10, 6, whatever. And you know that if it doubles, it is a sign of recurrence, most likely. There are other possible things that it could be, but it is most likely a recurrence. So that's that would be my first thing, especially if you're dealing with expenses, people who are paying for these tests, the issue of resources. Now, having said that, if you are following someone or you have a question based on their symptoms or based on a climbing CA125, and you get a CAT scan and it shows you have a new nodal disease, you have a new ascites, a new peritoneal metastasis, you have your answer. You don't need to add a PET CT scan. I sort of see the PET CT scan as the diagnosis, that the test you're using when you don't know what's going on, you have an elevated CA-125, your regular CT scan is normal, you're looking for something that you can't quite pick up. And again, it's a fine test to get if you have all the money in the world and all the resources in the world. So I would think of it more in a stingy manner of, if you have only so many healthcare dollars to spend, what do you want to spend it on? And I would say start with the CA-125 and go from there.
Okay, thank you. There is a question from Namkha Durji. He is from Bhutan, Dr. Namkha Durji. His question is, do you practice IRAS in your center? Dr. Sabrina Kadir, please. Sabrina Kadir.
Yes, ma'am. Assalamu alaikum.
Yes, please answer. He is Dr. Namkha Durji. He got the master degree from our country, from Bangabandhu Sheikh Mujib Medical University. His question is, do you practice IRAS in our practice, in our center? Please answer this.
Thank you. Yes, we practice IRAS some sort in our center. Preoperatively, we usually we usually tell patient to take bath every day, clean her abdomen, clean her perineal area properly, and don't allow her to shave that area. And then we don't make her NPO preoperatively, and we allow her to take 2 glasses of oat saline at 4 to 5 hours before operation. And preoperatively we give antibiotic, and paraoperatively we properly maintain glycemic status and fluid control. And postoperatively, on postoperative day, if bowel sound, if she passes, bowel sound is present, we give her oral feeding. And we don't continue catheter for long time. If everything was bladder handling was not so much done in operation, then we remove her catheter postoperatively, first postoperative day. And this is the way. And we also give her to do respiratory exercise. We allow her to do spirometer, and spirometer is not always available in our country. So patients are poor, so they cannot avail that. So we allow teach them to use balloon, and ballooning, it will help them to respiratory exercise. And we mobilize patient very early, and this all the preoperative, paraoperative, and postoperative protocol from IRAS we follow in our center. Thank you.
Thank you, Dr. Sabrina. Dr. Sabrina has given the message that, as you know, our patients, there we are not a standard, the international center, but we are trying to maintain the IRAS practice as per the availability. As Dr. Sabrina has told you, that our patients after admission, we encourage them and we educate the resident. They always educate them how to take their personal hygiene. At day of the admission, we advise them to take minimum the 4 egg white for every day, minimum 4 egg white. And every day he will have to do the breathing exercise, how they can do either the balloon, how they can inflate the balloon. And not only that, we don't keep the mechanical, the bowel preparation, only we give the patient either the glucose, in oral glucose, or either oat saline. And before going to OT, at the morning they take a shower. And during perioperative time, we have not maintaining all the temperature in that cases. And not only that, immediately we don't give the routine, the nasogastric, the tube. And also immediately when we can, the flatus passes with immediately on the day of the surgery, usually the patient is mobilized, and immediately we remove the catheter. And this way we can maintain this type of the IRAS practice in our center. And another question is from Dr. Shisho Ghosh. Preoperatively, do you give 1 dose of injection Clexane? Doctor, preoperatively, usually routinely we don't give, but in some cases, the patients who are the high risk, in those cases, we are using the Clexane. And another question the 60 years old Dr. Kares Namik, the 60 years lady, the underwent total abdominal hysterectomy and right-sided salpingo-oophorectomy many years ago. She did not know if it was cancer or not. Now she presented with left ovary low-grade mucinous carcinoma. What are the best treatment options in such case, please? Probably Dr. Manush sir has joined again with us. I request Dr. Manush sir to answer this question. Sir, please.
Good evening to you, Dr. Shana, and good evening also Dr. Anne Catherine and all the people who have joined in. Thank you. Dr. Shana, if you could just repeat the question in short.
Sir,
Yeah.
a 60 years lady underwent total abdominal hysterectomy and right-sided salpingo-oophorectomy many years ago. She didn't know if it was cancer or not. Now presented with left ovary low-grade mucinous carcinoma. What are the best treatment options in such case, please?
So once this is diagnosed, if you already know that that is the diagnosis, so the best thing is to find out first that whether it's a disseminated disease or it's localized to the pelvis. And if it is disseminated, whether we will be able to achieve a good cytoreductive surgery in the primary setting. That means right in the beginning, we can go ahead and do a staging laparotomy. And if in a primary setting, we are able to achieve a good cytoreductive surgery, they will go ahead for a primary cytoreduction in this case, and then take a call. However, if the indicators and pointers are towards disseminated disease in the abdomen, or if it is a disease which is gone, if it's also presenting like with a pleural effusion or cervical nodes and showing a stage 4 disease, then most of the centers we would give a neoadjuvant chemotherapy and then go ahead with that. After that, we will assess 3 cycles and then we will operate. That's what we would do.
Okay, thank you, sir. There is another question from Taslima Nigar. How can we improve serum albumin level before surgery in low resource setting?
I think that is exactly what you have already, said in your ERAS kind of protocol that 3 days pre-operatively you are, trying to give the white of egg to the patients. Otherwise, of course, we need to then give a high protein diet. But I think what you said was okay, but there's no very specific method as such.
Okay, thank you, sir. Would you prefer observing and the asymptomatic patient with no radiological evidence of recurrence on CSCT and rising C125?
Okay, so this is a problem which always occurs, that there is a rising CA125 and there is no radiological. So so what we would do is we would definitely follow up this patient. If there is no radiological evidence, probably in that case, so basically what we would do is to follow up with CA125. Just keep the patient under very, very close follow-up, because if there's no imaging which is showing any disease recurrence, is not much to do. We would follow up.
Okay, sir. But sometimes we have seen that there is C125 level is not raising, but on.
Yes, but if imaging, it has to be something. I
Yes.
mean, otherwise we go ahead with, in a recurrent setting, we can always go ahead with the PET CT. And like Dr. Anne Catherine said, we have to choose a PET CT depending upon how much money we have,
Yes,
whether the patient is affording or not. But the initial CECT would be able to tell us if at least there is some kind of, we are looking at a recurrence at some place. But if we still are not able to, then yes, but then we may just try and do a PET CT. Otherwise, without an imaging, without proof, with imaging, if there is no disease, then what? Because the role of doing a diagnostic laparoscopy today, the imaging has advanced so much today that the role of a check laparoscopy is only done in clinical trials, but not in the regular setting.
yes. And as sir, in the Indian and Bangladesh, now this Southeast Asian region, there we are the maximum centers and maximum patients. They are not capable of doing all the things. Even a CT MRI, it is also in that cases we can depend on the simple that is ultrasound, a good ultrasound, and also
Yes.
the tumor marker.
Yes.
There is another question from Suraya Begum, that is respiratory spirometer is only Taka 400 widely used in COVID patient. We can start to use it preoperatively in our onco patient. Yes, we are using routinely, we are using this in our hospital, and even some patients cannot buy it. In that cases, we ask them to make some balloon and inflate the balloon routinely preoperatively, so that immediately after surgery, that on the first postoperative day, they can easily do that. Another question is Dr. Shirsha Ghosh, that is, how do you diagnose mucinous carcinoma of the ovary preoperatively when it is a localized disease? Sir.
So if it's a localized, to diagnose mucinous carcinoma, I think today with good imaging, they do give us a good imaging, both ultrasound and CT MRI. The echogenicity is quite clear, and most of the radiologists are able to give us a clear, good a report saying that it is likely to be a mucinous cystadenoma, cystadenocarcinoma. So that way we can diagnose. The other thing is that having excluded, if you are doing a CEA and a CA 125, having excluded any GI, primary, and if the CA is high, then probably there's another little indication that it could be a mucinous. So basically, I think it is about the imaging which can tell us if it's mucinous or not. But is that very important? Because what we are ultimately going to do is we are going to do a staging laparotomy.
Yes, sir. Another question is Dr. Vishwarya, is how much would the preoperative laparoscopy help in deciding on possibility of the complete cytoreduction regarding the plane of dissection? Is it possible to really make out on laparoscopy?
So, there are good studies on that. In fact, so basically, today, when we are going in for let's say a primary cytoreductive surgery, then in those cases where their imaging has suggested that there is some amount of upper abdominal disease, we at our center, we do put in a laparoscope, and we then go through the entire abdomen. But there is a point of caution here. Many people would just put in a scope and not put a second manipulator or a third port. If we just by putting a scope without moving the intestines, we really cannot make out what are the planes, or if the tumor is how good are the planes. We may be, by putting a scope, we may be able to just make out if there is a small disease on the small intestine. That is the only thing which we can make out. However, to see if the mesentery is involved or not, we need to move the intestine, portion by portion, and see how much is the pliability of the intestine to see if the mesentery is involved. So when we are doing a serious diagnostic laparoscopy prior to doing a surgery, one should put in a scope, one should put in another 1 or 2 ports with a manipulator. Then only we can see. By only putting a scope, we either just see the surface of the intestine, or maybe go and see the diaphragm. Yes, if the we can see the diaphragmatic disease, and we can see the disease of the intestine. But diaphragmatic disease can be cytoreduced. The intestinal surface disease, that becomes a question. But mesenteric disease, sometimes most of the things are available on the imaging study. A good imaging can always find out how much is the extent, except for that small seedling kind of disease of the intestine.
Okay, thank you, sir. And another question from her is, in IDS setting, do we need to address the nodes that were enlarged during initial presentation?
Okay, so a very good question, I think. So what I think, what I understand from this question is that initial presentation, that means initially the nodes were enlarged along with the presentation. Then probably what the person is asking the question is that if neoadjuvant chemotherapy is given and then we are doing an interval cytoreduction, then do we need to go and cytoreduce those nodes or not? Now, as per the Lions trial, if we go by it, then if the nodes are all normal on palpation or having completely dissected, opened the peritoneum, retroperitoneum and the pelvis, if we have opened the peritoneum and clearly seen and palpated the nodes, and if they are of normal size, then we need not remove those nodes. But if you ask me what I do in practice, I follow that if the nodes were enlarged before giving the NSCT, I do a lymphadenectomy.
AK, what do you practice in your center, AK?
I told you,
Yes.
if the nodes were enlarged before
Okay,
giving the
okay.
NSCT,
Yes, sir.
then I remove the nodes. I do a systematic pelvic and para-aortic lymph node dissection.
AK, what
However, I have asked many other gynae oncologists, senior gynae oncologists, and some those who follow the Lions trial says that you need not remove the nodes.
Yes, sir. AK, what do you do?
What I would like to ask Dr. Anne Catherine, what should they do in their center?
Yeah. Okay.
I completely agree with you. I mean, ultimately, it's about optimal cytoreductive effect, right? So the Lions trial taught us that microscopic disease,
Yes.
removing it, the alter prognosis. We sort of kind of knew that just in general from our cytoreductive data on optimal cytoreduction versus suboptimal. So I agree that if you have obvious grossly positive nodes, if you leave them, then you have suboptimal cytoreductive. So yeah, I completely agree. I don't know that we have a policy per se, but I think that all my partners at Mass General also would do that. Yeah.
So do you not believe the Lions trial?
No, the Lions trial is about cytoreductive surgery in the absence of grossly positive nodes.
Yes.
All right. It was about the benefit of removing normal sized nodes, right? What we're talking about here is cytoreducing gross disease. That's different.
But
That's different.
There is enlarged node, and not only that, after getting the chemotherapy, all the miliary disease, we cannot see how much the miliary disease before the surgery. In that cases, how much it will be effective by doing this routine lymphadenectomy?
It's not a routine lymphadenectomy. I do not believe in a routine lymphadenectomy.
That's
what I'm
only
saying, you have one lymph node, it's 2 centimeters, it's full of tumor, take it out. That's it. I'm not saying remove all the other nodes around it. I mean, I just wouldn't. There are some times that from a tactical point of view, that is your strategy to get the job done requires you to open your retroperitoneal spaces, your paravesical space, your rectal space to get that obturator node that's enlarged and clearly full of tumor. To get that patient optimal, you need to do node dissection around it to clear it off. I mean, I've had to do node dissections because I need to control bleeding and I need to do a hypogastric artery ligation, and to get down to that, internal iliac vessels, I need to clean off the nodes. I'm doing them for strategy, not because I'm doing them just to remove nodes that are not enlarged. So that's the difference. In terms of the issue of miliary studying that you see at interval cytoreductive surgery, The standard thing that we would do is either a peritonealectomy, if you can do that, a diaphragmatic stripping, if we can do that. And if you have the resources, again, it's about resources, we have an argon beam laser that we use to actually directly laser and ablate miliary stuff on the diaphragm or on the liver and so forth. So it really, again, depending on your resources and your level of feeling that this is safe to do for your patient, there are those situations. I have to say, like just crazy, last week I had this a patient, interval cytoreductive surgery, very, very good chemo response, but she had this 3 centimeter perihepatic node. That was her only residual disease. And so I actually called in a hepatobiliary to resect that lymph node to make her optimal. I've actually never done that before. It was pretty spooky. We were right up on the right hepatic artery. But you know, again, we're doing it for the purpose of optimal cytoreductive surgery, which is to no residual disease. Yeah.
Thank you. There is another question. And before taking up a patient for the secondary cytoreduction for recurrence seen on CSCT abdomen, do you need to do a PET?
For recurrence, if a patient is for a recurrence, that is one of the areas where, PET CT really helps in a recurrent situation. However, again, we can take it up depending upon the, the affordability of the patient. We can do a CECT rising and the CA125 levels. We would know that there is disease. And then we would do a diagnostic lab on table before opening and do it. But PET CT would be a modality of choice in a recurrent setting.
Okay, sir. If there is a probability of the gut surgery for the ovarian cancer, is it necessary to insert NG tube? If yes, how many hours before or just before surgery? What is your opinion?
No, we don't put an NG tube, even if there is a gut LAR. Suppose we have to do a low anterior resection,
Yes.
and we are not putting any NG tube before surgery.
Okay, sir. I think we have no more questions. We are very happy. And probably the Dr. AK asked the different questions about the settings of the country and the future of the gynae-oncology. Probably Dr. Professor Samina Choudhury, madam. Maybe Dr. Samina Choudhury, madam, is she here? No, madam left. So I think we are, sir, do you like?
And
Your time is 8:30. 9 p.m. Bangladesh time and Indian time 8:30, sir.
Indian time would be 9:30, no?
No, sir. Now Indian time, sir. We are half an hour
Before.
No, you are half an hour before, sir.
We are half an hour. No, you are half an hour before.
It is 10:25 from Bangladesh and probably it is 9:55 in India.
Correct.
Yes.
So, so there was a presentation regarding investigation and workup of the ovarian cancer. That was what the
9 p.m. Bangladesh time. That is 8:30 in Indian time.
Did I make a mistake about joining in?
Yes, sir.
I had joined in earlier.
Yes,
and
sir.
then I thought I was early, so I came out.
No, sir. I have seen that you have joined. I thought that you have another program. So you
No. I was fully devoted to this program. I joined and I thought I was early. Anyway, so yes, it was the questions were very, very, very good, and I would love to answer if there's any particular other queries. But a lot of things are there regarding diagnosis. I think the topic was very well chosen, and so ours. So there is a difference in workup of a adnexal mass, suspicious adnexal mass. That is what is important in different types of centers.
Yes, sir.
The workup is different with the gynecologist. The workup is different with a tertiary care hospital, and a workup is different when the case directly presents to a cancer center like yours or mine. So the workup is totally different. So if we just talk about cancer center first, if it's a cancer center where all the facility is available, that means the most important is the frozen. The workup is basically for, when we do the tumor markers, it is not required for diagnosis because we are doing frozen. Your center also, our center also.
Yes, sir.
But what is important about doing the tumor markers is to know the baseline tumor markers so that we can follow up the patient well.
Yes, sir.
As compared to when the patient is diagnosed or is being diagnosed at the periphery. In the periphery, where the facility of a cancer center is not there, the importance is to diagnose the patient well and do the necessary transfer to a cancer center to give the best optimal treatment to the patient. That should be the aim. So in that situation, all knowledge which we have gained so far by all the gynecologists of how to diagnose a adnexal mass, whether it's a benign, whether it's malignant, and whether it should be tackled at a peripheral center or whether they should transfer it to you. That is what is most important. So with that thing in mind, I think it's already been discussed that that's the place where, a good ultrasound, in fact, a good CT or a MRI, whatever facility is available is important. Along with that, we, of course, all of us know what are the ultrasound features of benign and what are the ultrasound features of malignant. When we are, calculating the RMI index, that itself has those 5 factors, what are benign, what are malignant, that has already been, I'm sure it has been spoken about.
Everything is discussed about the RMI, the
RMI, everything has been discussed.
The iota adenix model and everything else, because sir, everything there we are discussing it in our tumor board. Even after that, we are missing something. So we have given the emphasis on the describing the preoperative, the workup, and then we like to discuss what are the importance of the advanced imaging. Sometimes we think that ultrasound it is enough, so we do not go for the advanced imaging. We have seen the thought that we'll discuss in disease wise in all the topics, that is how should we go for the surgery, and during surgery how should we evaluate the abdominal cavity and explore the abdominal cavity, and what is the importance of the writing the operation note, and how much we have removed and how much not, and histopathology reporting. And I think we'll include it individually in every cases. And I think in between the tumor board we want to discuss in future.
True.
And as because the maximum our OBGYN colleague, they are joining in this program, more than 100 the participant every day.
Yes, I see lot of participants.
Yes, I think they will get the message from here and they can practice their patient in their centers.
Yeah. So the important is basically to find out which cases they should do in their center and which cases they should send to advanced center so that the patient gets the best treatment. That remains the most important, I think, and that's how the gynecologist have to get the knowledge and make a good decision whether a patient should be transferred or whether they should do. So one very simple dictum I use, I must share. So having investigated a suspicious adnexal mass, a very clear one has no problem. Ascites, deposits, that is not a problem. The problem is when the disease is localized in the pelvis as suspicious adnexal mass. So when all the investigations which as a gynecologist we do, and when it is likely benign, then one can go ahead and tackle in your own center and do a laparoscopic surgery. When it is likely malignant, then please transfer the patient to a higher center. So likely benign, likely malignant. All investigations suggesting likely benign can do laparoscopic surgery, go ahead in the center. Likely malignant, please transfer. this is what I follow, and I always tell the gynecologist.
Sir, there is another question. If there is a need of gut surgery, who does it? You call surgeon or
Yes.
gynecologist?
So as of now, our board certification or our certification, we were trained when before the full MCH program started. So when I have a gut resection to be done, then I call my team member who are the GI onco in the same team. However, today, if one has done full 3 years of gynec oncology, and gynec oncology training should include 6 months in urology and 6 months in in GI surgery. With that knowledge, the gynae oncologist should be able to do all gut resections and should tackle all urological anastomosis and corrections. And that's what I have. So I've gone and seen. So the gynae oncologists are doing everything, including liver resection.
Yes, sir. Yes.
Where they are fully trained. Not all gynae oncologists would do liver resection, very few. But otherwise, gut resection and anastomosis by staplers to do surgery which is involving the bladder or the ureter being ileal conduit and all, the gynae oncologists should be able to do. Since during our training it was not so we are not doing. We are calling the respective GI oncosurgeon.
Thank you, sir. I think we are at the end of the session. There is no other questions. So before that, I would like to request, and I am very much grateful to all our faculties and all the participants. Without them, the participant, we can make the program the fruitful. And at the end of the session, I would like to request the chairpersons of today's session, our president of the Oncology Club, Dr. A. Bhai sir, to conclude the sessions, and the Dr. A.K. Goodman, she has asked some questions. I think sir will answer it properly, and sir end the session.
Thank you, Savana. Can I tell me the question? Can you please repeat the question?
A.K. asked. He has asked what are in the situation of our countries, the cancer patient treatment, and what was previous and what are doing, and our referral of the patients and how the patients are dealing in our country. Dr. A.K. she asked the question too.
So we yet to be developed these things. We cannot we are trying to develop this, I say, this referral system, all this thing. In fact, it was in my team when I was the director of Cancer Institute that everywhere it shall be able to train our consultants who are working in the peripheral hospitals about the diagnosis, early diagnosis of cancer, and refer them to the tertiary level hospitals. And they refer that. That was the idea. But still, some advice and has been taken to place, but still we have to develop this referral system. And the measure we are now taking about the training of this for gynecologists, not only gynecologists, but gynecologists who are to deal with this oncology patients. So there is this today's lecture was for them to enlighten them to assess the pre-assessment ritual. Actually, what the problems they are facing in doing this proper assessment in pre-operative. So they can open their ideas, or possibly we shall be able to help them through these workshops, how they can do the proper assessment pre-operative. This is how we are trying our best. Hopefully, we shall be doing. Can you suggest anything?
Okay, do you like to suggest anything? Yeah.
No, I think it's I find it fascinating. You know, as I said, all of us, everyone in this room together here, our electronic room, we are all clinicians. We take care of each patient one at a time. We are also educators. We teach the next generation and the generation after that, and we teach and receive teaching from our peers and from our seniors. It's a wonderful place that we live. The interesting thing to me is our intersection with public health and our intersection with policy and infrastructure. You and I cannot build a hospital. You and I cannot allocate gross national product, right, the GNP of a country in terms of what is allocated to take care of the health of its citizens. That comes from policy, that comes from government, that comes from Ministry of Health. It's a very interesting, different world that we always ask, you know, we'd love to have a few more radiation machines and so forth, but we don't have control over that. So what we do is the best we can do. We take care of patients in front of us, and we do education, and we do outreach. And this amazing tumor board that you all have put together is an example of this interconnectedness to do the best we can. It would be very interesting, just as a suggestion for future teaching, to invite somebody from the Ministry of Health to talk about public policy. Because I recently listened to a wonderful lecture, actually on the obstetrical side, talking about how we blame our patients for their individual failures of not taking good care of themselves or this and that. But what we don't see is the environment that they live in that challenges their health, whether it's because they don't have access to food, they don't have access to safe housing, or they don't have access to the medical world. So there's a lot of other things that we don't have control over, yet we live in that environment. So that's just my point. It's a fascinating thing to me. That's a bigger level of inquiry from what you and I can do. So just as a suggestion, if you have the ability to invite one of your august ministers of health who has a policy look and ask, what is the National Cancer Plan? How can we improve upon it? How do you see that? That would be very interesting to have that discussion. Yeah.
Thank you for the suggestion. We're trying to do this for a very long time. We had a plan also, but it's very difficult in this country to follow this plan and do this. We have infrastructure, health infrastructure up to the village level, but still then there is some problem. We're trying to overcome all these things, hopefully, future, near future. The government has already taken steps to develop newer cancer centers. So hopefully, if we go to the division of our country, we will be able to go nearer to the patient. That will be good. Hopefully, we always hope, let us hope. So thank you all very much. And all the participants. Hopefully we shall meet again in next session. Roxana, thank you very much. And I think we should conclude already.
Thank you, sir. Thank you, Dr. Shana.
Thank you, sir. Thank you very much. There's a message to Dr. AK and Manoj sir that we are not the policy maker. It is all the policy maker. They can do this.
That is why I did not say anything about policy. Because it is what Dr. Ann said, of course, is so true. You know, everything is, you know, the overall development, overall infrastructure development is always politically driven. We all know that.
Exactly. There should be some political.
We all know. The minister wants it, then they will put in funds. So all these screening programs and, you know, the cancer center growth, everything, it's all politically driven. So once if they do it, the infrastructure improves. But we have a good system of improving our education, teaching the youngsters, imbibing the thing from the seniors. Exactly what Dr. Ann mentioned. All of us.
What we can do, I'm doing this. You have to know all the problems.
Yeah.
How far we can do, we're doing this now.
Yes.
We're doing this as far as-
Everywhere it is the same.
Yes, sir.
Not that everywhere it is the same.
Yes, sir. What we
Thank
are
you.
doing on a personal level, and also that
Yeah.
through this small focus group discussion by this type of platform.
But this platform is so good, so good. Earlier also I have said that this oncology
Because of your,
doctor-
because of your participation.
Yeah.
Your help.
Yes, we are also grateful always the AGO and also the Dr. AK, they are always the supporting us, and for that reason we can continue this. Hope you people will support us, sir. Thank you very much. Thank
Sure,
you.
sure. And sorry, Dr. Tohima, I was a mix-up about the timing. I kept myself free, absolutely, to hear your presentation. But
Thank you,
next
sir,
time,
for your
definitely,
participation.
I will make sure that it is on time. I'm there.
No, it's okay, sir. Thank you. Thank you, sir.
Okay. Okay.
Thank you, sir. Thanks to all.
Okay. Good day, ma'am. Bye.
Okay. Goodbye, everybody.